Good afternoon, everyone. I am Rahul Gosain.
And I'm Rohit Gosain.
And we are Oncology Brothers. In the year of 2022, we've seen a lot of exciting data and approvals in the world of oncology. But there's one study that stands out and has resulted in a paradigm shift, as we can still hear the claps from the standing ovation at ASCO 2022. Here with us today, we're excited to have a world-renowned medical oncologist, Dr. Shanu Modi from Memorial Sloan Kettering, to talk us through that study, her study, DESTINY-Breast04. We have a lot to learn, so let us get started and welcome Dr. Modi.
Hi, thank you. Thanks for having me here. I'm really excited to talk about DESTINY-Breast04 one more time.
Thank you so much again, Dr. Modi. Dr. Modi, to begin, can you please walk us through the study design of DESTINY-Breast04 and its primary and secondary endpoints, please?
Sure. So, this was a randomized phase 3 trial, and we were looking to compare this new HER2 antibody drug conjugate, Trastuzumab Deruxtecan, versus standard chemotherapy that we commonly use for patients with advanced stage breast cancer. And so patients specifically for this trial had to have what we call HER2 low metastatic breast cancer. And that's really the key here, of course. So, we've traditionally thought of breast cancer as either HER2 positive or HER2 negative. HER2 positive breast cancers are driven by the oncogene, and they're sensitive to our currently available HER2 targeted therapies, of course. And so we tend to group everything else or everyone else as having HER2 negative breast cancer. So low levels of or not high levels of HER2 and not sensitive to our current drugs. But we know it's really an oversimplification, this binary classification. And even within HER2 negative breast cancer, there is a large population of patients that have tumors with low levels of HER2. And so we've called these HER2 low breast cancers, and we define them as tumors that have IHC scores of 1 plus or 2 plus without gene amplification. And so this was the population that we identified for this trial. So tumors that were HER2 1 plus or 2 plus without gene amplification. And these patients, after, of course, it's still a heterogeneous group. There are hormone positive patients within this group. There are hormone receptor negative breast cancer patients within this group as well. And so they come with a lot of prior different therapies, of course. So for this study, what we required was at least one line of prior chemotherapy, but not more than 2. And for the hormone positive breast cancers, those patients had to have at least one line of endocrine therapy and had to be considered to have endocrine refractory disease by their treating oncologist. So there was no limit on prior lines of therapy. So that was the population. I mean, and whether they're hormone positive or hormone negative, this is a population that's now gone through 1 or 2 lines of chemotherapy. So they have fairly refractory disease. And so we randomized these patients either to T-DXd, Trastuzumab Deruxtecan, which is the new HER2. It's a new generation, of course, HER2 antibody drug conjugate. Versus a standard chemotherapy. And there was a choice between gemcitabine, capecitabine, paclitaxel, nab-paclitaxel. So some of the commonly used, and eribulin, some of the commonly used chemos we would use in this setting. And the primary endpoint of the trial was really to look at progression-free survival. And this was by independent review. And the population was the hormone positive HER2 low population specifically. That was the primary analysis group. And that's because within HER2 low breast cancer, the predominant population is hormone positive breast cancer patients. It's almost a ratio of 9 to 1. So it's vastly populated with hormone positive patients. And so in many ways, we designed the trial initially for that population. So it was hormone positive, HER2 low, and that was our primary endpoint. But recognizing that the mechanism of action of this ADC could extend to even hormone receptor negative patients, we did end up revising the original trial design. We included hormone receptor negative patients, but we included them in a proportion that's what we would see in HER2 low breast cancer. So mostly these were hormone positive patients, and then a smaller group of hormone receptor negative patients. And so we planned a hierarchical analysis. So after looking at PFS for the hormone positive patients, if that was positive, we would then look at the PFS for the entire study population, this time including the hormone receptor negative patients. And then similarly, if that was positive, we would go on to look at overall survival in the hormone positive, then all patients on trial. And there were a variety of other, of course, secondary endpoints that we looked at.
Dr. Modi, you mentioned that low HER2 is very common in hormone receptor patients. How prevalent is low HER2 in triple negative disease?
So if you look at the HER2 negative population and now look at it by hormone positive and triple negative subgroups, about 2/3 of hormone positive breast cancers will be HER2 low, and about 1/3 of triple negative breast cancers will also be HER2 low. So it is you can see it's a mixed population.
Thank you. And of course, the results, everyone knows about it. We got standing ovation for this at ASCO 2022. What did the results show?
So for the primary endpoint, of course, which was the key efficacy endpoint, I mean, we were really excited to see the PFS curves. I think those are the top curves you're showing there. Um, they separated early, and they remain separated throughout the follow-up of the trial. And you can see there's a clear advantage here for the T-DXd arm. The hazard ratio was close to 0.51, I think, in the hormone positive population, which means there's a 50% decrease in the risk of a progression or survival or death event in the T-DXd population. And then when we, having seen that positive, and so I should say the median progression-free survival improved from about 5.4 months, that's with standard chemotherapy, just to over 10 months in the T-DXd arm. And we saw a very similar, almost identical pattern in the total study population, now including the hormone receptor negative patients. So a hazard ratio of 0.5 and basically a doubling of the progression-free survival. When we then moved on to the overall survival results, so a key secondary endpoint of the trial, here the hazard ratios, again, identical, frankly, in the two hormone positive and full study population, 0.64. And we saw basically an absolute gain in overall survival of about 6 to 6.5 months in these patients. So, a median survival with chemotherapy in this setting is about 17 months on average, and it could improve almost to 2 years with T-DXd therapy. So it's really exciting.
Wow, that is amazing. I mean, I'm still getting chills thinking about the ASCO room there. Congratulations, Dr. Modi, and to all the patients and their families involved with you in the study. The study
Thank you.
was in fact presented at ASCO 2022 June this year. Since then, T-DXd got approved in August 2022. Now, diving a little deeper into this, in our clinical practice, would you recommend retesting the tissue for HER2, or is it okay to just rely on the initial biopsy to make further decision?
So that's a great question, and there's been a lot of interest in understanding the tissue characteristics of the patients on this trial. And so we did actually present some details from that just at this past San Antonio meeting. It was in a two presentations, a spotlight poster and a second poster presentation. It's important to, I think, clarify that the study required one sample only. And of course, we requested the most recent sample, but that's not always possible, and there's sometimes not enough tissue, or perhaps in some cases a metastatic biopsy wasn't performed. So in the end, we actually tested or centrally confirmed the HER2 status in 1/3 of the patients on this trial from the primary breast cancers, and 2/3 came from a metastatic site. So that tells you already that there were, we looked at a variety of different samples. So I think that gives us all a little bit of confidence that you can go back to an archival sample. If it is HER2 low, you can use that to consider T-DXd for that patient.
Dr. Modi, when we were talking about sampling, you alluded to this. Prior to this study, we were living in a binary world where something was HER2 positive or HER2 negative. And that is how that test was designed. The IHC test was used to call something positive or negative rather than be
Right.
very sophisticated to be called HER2 low. And we've seen a significant discordance of something be called HER2 low, especially in the community settings. How would you recommend we battle that challenge in the community settings?
You're right. IHC was never really meant to be used in this fashion. It really was meant to identify 3+ and those patients who would be sensitive to our standard HER2 therapies, and everyone else was really, didn't. Our pathologists didn't spend a lot of time differentiating 2+, 1+, and 0 because it had no clinical impact. But that's changed now. And so for most places, I think where pathologists are used to scoring using IHC, I think these results will be readily available. And I think we have shown that you can rely on 1+ and 2+ to find patients that will respond to T-DXd. And for the future, look, there's a lot of work ongoing now looking to see, can we use different assays, more quantitative assays, and even different biomarkers entirely, maybe biomarkers of the payload to select the optimal patients for this therapy. But I would say the one thing Destiny Breast does show us that using a widely available, routinely available assay, IHC, you can identify patients who have the potential to benefit from T-DXd.
Thanks for the information, Dr. Modi. Now, dissecting this further down, patients got repeat scans every 6 weeks on the study. Now, outside clinical trials, how often do you repeat scans in patients who are currently on T-DXd?
Right. It's a great question. We get asked that a lot too, and usually with regards to the lung toxicity. So on the studies, the scans were actually being done Q6 weeks to look for efficacy, right? But of course, we were using those to also look out for lung toxicity, which we know is an important toxicity of this drug. What we do in clinical trials, of course, is not necessarily something we can always extrapolate into our community settings. And getting payers to cover a CAT scan every 6 weeks is virtually impossible. I think what we have found just from discussions, big discussions amongst colleagues in different settings, that many treating oncologists are able to get scans every 9 weeks, roughly. So look, there is benefit in identifying lung toxicity early. You can intervene early, you can start therapy early, you can perhaps reverse it and then have the opportunity to re-challenge. And if you miss an early point, patients become symptomatic with their lung disease, you're no longer in a position to be able to reuse the drug. So there is some value in finding lung toxicity early, and safety, of course. And so I do think, or I do counsel people, try and do CAT scans as the chest specifically, between 9 to 12 weeks, and I think that's a reasonable interval.
Thank you. As we were talking about toxicity, I think this is a good point to jump in. GI side effects and overall fatigue were also common. And of course, you alluded to ILD. And it's also important to reiterate that these patients, even if they've been on T-DXd for months and months and months or years, you still need to keep up with those repeat scans frequently. How do you manage some of these side effects in your clinic?
So one thing we've learned, I think, from the whole breadth of T-DXd trials is that nausea is the most common side effect from a day-to-day perspective. And in many of the original trials of T-DXd, patients were not given prophylactic antiemetics. We know we should give patients prophylactic antiemetics, so that should be standard at your institution. I mean, as you would treat someone with an anthracycline. I mean, you would not give someone an anthracycline without antiemetics. So the same thing goes here. And currently in the NCCN guidelines, this is listed as a moderately emetogenic drug.
Excellent.
I think that is actually going to change to become recategorized as a highly emetogenic drug.
Oh, wow. Okay.
And so I do think like double or triple therapy prophylaxis should be mandatory. One can always peel back, of course, but I think you want to start by preventing nausea up front to avoid that anticipatory nausea that can develop. So a long-acting 5-HT3 antagonist, steroids, maybe a neurokinase inhibitor, neurokinase 1 inhibitor. There are a few options, of course. Olanzapine is often used as well. So think of your anthracycline patient and what you might give to someone you're giving AC, for example, and that's what I would use to premedicate patients on T-DXd. It's so important to always underscore and highlight the importance of active surveillance of patients on this therapy, and that means educating the patients, educating the staff, taking care of the patients, asking them to report pulmonary symptoms, new symptoms, or worsening symptoms, and taking those seriously. And really what that means is stopping therapy first and foremost. If there's ever any question of lung toxicity, the first thing is do not redose that patient, and then start your investigation. That would include high-resolution CT scans, perhaps involving your pulmonology colleagues. Occasionally, we've had to bronch patients to differentiate, infections or atypical abnormalities from lung toxicity. And at the end of the day, it's really a diagnosis of exclusion. And if you can't exclude it, then I think it's fair to say you have to assume it's lung toxicity. And again, there really widely available guidelines now to help clinicians, in general, grade 1, so asymptomatic lung toxicity. If it fully recovers, meaning your CT scan goes back to baseline, those are the patients you can consider a rechallenge of T-DXd. In every other scenario, grade 2 or higher, if they have any respiratory symptoms with those radiographic findings, you're stopping, you're treating, even if you see resolution, those are still patients we today do not recommend you rechallenge with T-DXd until we understand more fully the pathophysiology and what could or could not happen. So again, it comes back to, doing those CT scans at regular intervals so you do have the ability to intervene early.
Dr. Modi, thank you so much for covering that. And before we close, one common scenario that we run into now ends up being, how are we going to sequence these therapies? We have more than one ADCs approved, particularly in triple-negative breast cancer. We've seen data from sacituzumab for second line, and it is approved in that settings. Now we have T-DXd, a patient that has progressed on first line for triple-negative and now has low HER2. What is your go-to drug?
Yeah, this is a problem as clinicians we are going to be facing more and more often as a lot of these new generation ADCs come. It's a great problem in some respects.
Absolutely.
We currently don't have a way to determine the right therapy for patients. I would say that I believe the data from DESTINY-04. It was a smaller population of patients that had triple-negative breast cancer on this trial, but they had such robust results, clinically meaningful results, hazard ratios of 0.46, 0.48, very similar to the ASCENT trial, frankly, and sacituzumab data. So I believe it. Having said that, we have a much larger level 1 body of data for sacituzumab in the ASCENT trials. Specifically, those were studies for triple-negative breast cancer patients. And so I think for the moment, I do tend to prioritize sacituzumab for my triple-negative breast cancer patients, even those with HER2 low. Although, I think on a case-by-case basis, I would be really comfortable using T-DXd before sacituzumab for some of its unique advantages, including the extremely high response rate, and the rapid onset of response, And so for some patients, if you have a limited opportunity to make a difference, that may still be a reasonable drug to use even before sacituzumab.
Certainly a great problem to have. The art of oncology continues to get better by the minute.
Right.
To sum up the year of 2022, we could not have found a better study to discuss. Dr. Modi, your work around T-DXd has given our patients more time with their loved ones, and these patients are living much longer. Dr. Modi, thank you so much for being with us today and discussing this important study, and congratulations once again.
Thank you so much. It's really been a pleasure for me to be here as well.